Tantor Audio, a division of Recorded Books, presents 12 Cases, a psychiatrist's true stories of mental illness and addiction and other human predispositions. By Daniel Mierlak, M.D., Ph.D. Narrated by Patrick Lawlor. Author's Note: the following cases are true, but to protect the individuals involved, names, dates, locations, and other identifying details have been scrupulously changed. It is important to note that no claim is made as to how psychiatric disorders ought to be treated, and none should be taken from the specific treatments mentioned. Everything has been figured out except how to live. Jean-Paul Sartre. Preface. Judging from the questions I've gotten over the years when someone new learns I'm a psychiatrist, many people seem genuinely curious about what goes on inside the office of a shrink. And why shouldn't they be curious? The capacity of human beings to surprise and to shock is impressive. The media is full of reports. Perhaps you've noticed stories recently of unseemly behavior from public figures. Or how about these examples much closer to home? Reflect on your own fantasy life for a few minutes, or better yet, behaviors that you keep secret or wish you could. If you're honest, you'll have to agree with me. We are all capable of the provocative. There's no question that psychiatrists do some of their work with patients out on the darker edges of the psyche. Who wouldn't be interested to hear about that exotic landscape? The stranger versions of human experience are just plain fascinating to so many of us. And even if you claim disinterest in matters of psychopathology, even if the lurid is not your particular cup of tea, at the very least it can reassure to learn that some people out there have more issues than you do. I completely understand these brands of curiosity. After all, I decided to pursue psychiatry as a specialty nearly 30 years ago. But psychiatry is not like other medical disciplines. The sensitive nature of the symptoms we delve, involving as they do our thoughts, emotions, and behaviors, sets a higher bar for confidentiality. Because of this, access to authentic accounts of psychiatric practice for the general audience is harder to come by. Yet flying in the face of this thoughtful discretion, there seems to be no shortage of popular culture stereotypes of psychiatrists and psychiatric patients in films, television, and fiction writing. Like all caricatures, these depictions lack nuance and are easy prey for the cynical to belittle a couple of already beleaguered groups. You would think that so long as I kept identity secret, I'd be in a good position to satisfy the inquiring mind about the private conversations I have with patients and set the record straight on biased misconceptions. Despite a career of it, though, I must admit it has not been easy to explain my work. I've had trouble when asked to describe what the practice of psychiatry is really like. My responses have been too often generic and fail to hit the mark, as this exchange with my kids, one of many attempted, demonstrates vividly. I help people with their problems by talking to them and sometimes giving them medicine. "What kind of problems, Dad? What do the medicines do? You talk to them and they get better? You get paid for just talking to people?" Okay, so maybe the profession is legitimately somewhat opaque. On the other hand, I may be taking the wrong approach to try to summarize psychiatry. It seems an inherently lame exercise. As I've thought about it, there is probably a simple reason blanket statements about psychiatry don't work. It's the same reason blanket statements about romantic comedies don't work. People are interested in stories with characters and action, not formulas. And in psychiatry, as I've come to see, it's the story of the treatment, the meandering journey of collaboration between patient and doctor that lies at the very center of the curiosity which yearns to be a fly on the shrink's wall. Therefore, I present the following 12 cases as my answer to what it's like to be a psychiatrist. Think of each as a stroll through a single gallery of a very large museum. In these stories, I take you away from fictional, stigmatized renditions of psychiatry and instead drop you into actual hospital wards, into my private office, and in one instance, into a house call. The way psychosis, mania, and depression unfold, the particulars of four-point restraint, electroconvulsive therapy, and overnight call, the management of suicidality and homicidality, and the wild horse of addictive disorders are some of the circumstances that await you. Strange as these real accounts read, the underlying struggles they reveal are familiar. At heart, these are stories of individuals who grapple with their demons, something that I suspect can resonate with us all. Remember my little thought experiment about your own fantasies and behaviors? You will find a part of yourself somewhere in these tales. On a personal note, I sometimes get asked how the work with psychiatric patients has affected me. I trust some of the unusual challenges I have faced will come through in the cases described in this volume. You can decide for yourself how well I negotiated them. The truth is, the unexpected plays such a central role in psychiatric practice that it's impossible to succinctly sum up the impact of a career in psychiatry on oneself. But I'll try anyway. If there's one thing I've learned from working with patients, it's this. As much as we think we know someone, ourselves included, there's always more. So now, for those interested in a rare glimpse, if I may open the door, please follow me inside. Case 1. First Do No Harm. A popular storyteller's device is to start at the beginning, and to the extent this collection traverses an arc, it fits that our first case is almost literally the first case of my career as a psychiatrist. It occurred during the initial weeks of residency training and takes us deep into the psychiatric hospital. Anyone who remembers the anxiety of starting a new job or a new school or a new anything will realize some familiarity in this account. As for the rest of the details, I hope few find recognition, for the action described concerns paranoia and violence. That this case unfolds on a locked inpatient psychiatric unit is apt. Certain impulses are best managed in protected spaces. The therapeutic relationship between doctor and patient is where the work of psychiatry takes place. It is prudent for the psychiatrist to remember that patients can form profound attachments within that space. It all started with a slap in the face. July 1990. I was a freshly minted MD, less than 2 weeks into internship, the first year of residency training for all physicians. Psychiatry had a 4-year residency, and the internship year consisted of rotations on the hospital services for medicine, neurology, and psychiatry. I had drawn a schedule that started with 6 weeks of inpatient psychiatry. Tactically speaking, this was bad luck. In a year that would crush my notion of endurance with brutal stretches of overnight call and endless tasks on very sick patients, the psychiatry rotation was considered vacation time. Case in point, there was no overnight duty for interns on psychiatry. Not only did I lose the option to have a soft rotation later in the year, even worse, I would start medicine 6 weeks behind all my colleagues. They would be weathered, and I wouldn't have developed any calluses yet. The psychiatric hospital I trained at was the Payne Whitney Clinic, part of the renowned New York Hospital Cornell Medical Center in Manhattan. The clinic stood separate from the main hospital complex and was connected by an underground tunnel. There were 5 units for inpatient psychiatry, each on a different floor. The second-year psychiatry residents ran 3 of the units. The remaining 2 were smaller, one run by faculty, the attending unit, and the last a research unit focused on schizophrenia. Interns were assigned to the attending unit for their psychiatry rotation. Even though it took admissions from the same patient pool as the resident-run units, the attending unit was known to be temperamentally calmer. This cut both ways for the intern. On the one hand, it meant a gentler introduction to the most difficult psychiatric patients, but on the other hand, it could feel like a coddled, watered-down version of what was to come in the second year. I arrived on the attending unit, Payne Whitney 5, one early July morning to learn I was getting an admission. Still a rookie to the whole process of admitting patients, my pulse quickened. The patient was a transfer from the 4th floor, Payne Whitney 4, one of the resident units, and had been admitted there from the emergency room just hours earlier. This was very unusual. Patients were rarely transferred between units. There was a tense vibe among the nursing staff. They had already been briefed on the case. The patient had been admitted to Payne Whitney 4 once previously, about a year ago. The nurses had good reason to be nervous. This patient, a woman, had just assailed the 4th floor head nurse. Upon arrival to work that same morning, the Payne Whitney 4 day shift must have felt disoriented. Their newest patient had already commandeered the energy and attention of the entire unit. Dressed in a hospital gown, she ran up and down the long hallway, agitated, shouting threats. When she came upon the head nurse, she was stopped by a startled recognition. Within the patient's disordered mental processes was the conviction that the head nurse had assaulted her during last year's admission. After screaming this delusional accusation to the gathered staff yielded little satisfaction, the patient roundly slapped the head nurse across her face. One of the most important functions of the psychiatric hospital is to offer safe and humane treatment for patients whose illnesses inspire violent impulses. The necessity for patient and society is obvious. Equally obvious is the likelihood that these patients, until effectively treated, will discharge their aggression within the walls of the hospital. Staff are trained to manage such events, but each is unique and often escalates rapidly and always evokes the fight-or-flight response from every witness. The protocol after an assault is standard and was well known to the experienced staff of the 4th floor. The patient is approached by a group of 5 or 6 staff members. There is one spokesperson agreed upon beforehand. With this show of force evident, the spokesperson calmly and with a firm but neutral voice tells the patient that they need to regain control of their behavior. They are usually instructed to go to a quiet area for a period of time to recover their composure. Sometimes medicine is administered. In this case, the patient was escorted to the seclusion room, a featureless room empty except for a mattress on the floor, and whose sturdy door housed a small, single pane of thick plexiglass. Despite her agreement to a tranquilizer, she did not quiet. On the contrary, she remained quite agitated, screaming and banging on the locked door. When she recognized another staff member from last year's admission, her verbal threats escalated and began to target him. At that point, it was clear she couldn't be treated on the 4th floor, and the transfer was decided. I think breakfast hadn't even concluded yet. The patient was escorted the 1 floor up to my unit by a phalanx of large male staff members. She was immediately placed in the private room closest to the nurse's station. In addition to all this special attention, her hospital gown further set her apart from the other patients. They wore clothes brought from home. I decided to give her some time to settle down, have some food, maybe take a shower. I also wanted to review her chart and learn more before introducing myself, so I took her thick binder to a quiet corner of the nurse's station and started to read. Her name was Amanda Kay. She was raised in Oregon, one of 6 children. Her parents divorced when she was 8. She then lived with various relatives. She described herself as always impulsive and moody. After high school, she moved to Los Angeles and started working. 2 years ago, she moved to New York, and her fortunes began to change. The moodiness and impulsivity amplified. She had a series of secretarial jobs that ended with her abrupt dismissal or her abrupt decision to quit, usually after an angry outburst. She met her current boyfriend about 1.5 years ago and moved in with him. This relationship did not have a stabilizing influence. She started to have bouts of paranoia, during which she believed others acted malevolently against her. Emboldened by an impulse control in retreat, her retaliatory nature caused her to respond to these perceived perpetrators as you would expect. She began to punch and kick strangers on the street because of what they had done to her. The boyfriend was not immune. Their increasingly volatile relationship achieved crisis status last year when she splashed Pine Sol into his eyes during a dust-up. That landed him in the ER and her on Payne Whitney 4 the first time. In 2 years, she had gone from difficult to disturbed. It was during that first admission at Payne Whitney that her diagnosis was narrowed down to a severe personality disorder versus bipolar disorder, manic depressive illness. Both conditions can produce elements of the clinical picture she presented with, but because other symptoms were teased out of the history, spending sprees, hypersexuality, periods of decreased sleep, and increased energy, the bipolar diagnosis was favored, and she began a trial of lithium, the gold standard treatment for bipolar disorder. Unfortunately for all, she didn't respond. Her hospital stay was filled with suspiciousness, hostility, visits to the seclusion room, and numerous rounds of medication to try and calm her internal storm. With only marginal improvement to show, she was nonetheless discharged from Payne Whitney 4 after a couple of weeks and referred to our outpatient psychiatry clinic for follow-up. For 6 months, she cycled through a series of powerful mood stabilizer medications for bipolar disorder. Each medicine produced an intolerable side effect and little benefit for the core symptoms. Our inability to help her was exemplified by the manner in which the treatment ended. The patient abruptly terminated after accusing her female therapist of sexual advances. After that, for a few months, she was not engaged in any treatment, not taking any medication, and not getting any better. On 2 separate occasions, she ran into staff from the 4th floor in the vicinity of the hospital. She assaulted them both and railed to the onlookers about her mistreatment. These were the same staff targeted by the patient this morning. About 2 months ago, her fortunes changed again. She became depressed. The aggression and paranoia quieted. She became withdrawn, then suicidal. In this melancholic state, she brought herself to the St. Vincent's emergency room in Lower Manhattan. They admitted her, but made a critical mistake. They did not take a careful history. Limiting their inquiry to present symptoms only, St. Vincent's formulated her diagnosis as atypical depression. They missed the bipolar disorder. The atypical depression conjecture led them to Parnate, one of the most powerful antidepressants available. Problem is, in a bipolar patient, Parnate can act as jet fuel and propel the mood out of depression, then through the entirety of the normal mood range and into full mania. They unwittingly gave the patient a medication that would very likely return her to the paranoid-driven aggression she had no control of and no insight into. It didn't happen right away. Initially, the medication lifted her out of depression and into a reasonably neutral mood. The suicidal urges dispelled, and the patient was indebted to be out of that hole. She saw Parnate as her savior from the darkness. Although feisty during that admission at St. Vincent's, she required no seclusion and was discharged before any shenanigans occurred. 6 weeks later, she was back at the St. Vincent's ER. The Parnate had done its work. She was agitated, angry, fighting with strangers, and unable to sleep. The hospital realized their error, admitted her again, and quickly added lithium for the bipolar process. They knew they had to slam the brakes on Parnate since it had become an accelerant to her mania. They began to lower the dose and explained the rationale to the patient. It didn't go well. The patient became enraged that Parnate, the only medicine that had ever helped her, was being removed. After that, she refused to take any medication whatsoever, stopped participating in treatment, and demanded to be discharged. Apparently, St. Vincent's had had enough of her, so they obliged and let her go. That was 3 days ago. Now she was in the room next door to me, paranoid, hostile, and fresh from an assault on a staff member. I closed the chart, placed it back in the rack, and took a deep breath. Reading the chart did not allay my anxiety. Actually, it had the opposite effect. I was a greenhorn to inpatient psychiatry and the dark capacities of the human mind. The most difficult patient I had managed thus far was Mr. Feldman, a schizophrenic rabbinical student who believed Jesus was a tall blond man with a large phallus. Peanuts! Amanda was the real deal, hatched from the reptilian brain, and she stirred up some old fears in me. I may have been new to psychiatry, but I was not a stranger to fear. I had my own secrets like everyone else. Since a little boy, I'd been deeply, paralytically phobic of hospitals, a result of my first visit to one on a Sunday to see my ailing grandfather, who unluckily died the next day. Briefly unattended in that astringent hospital room, I pulled back the curtain and saw my shriveled grandfather in a heap on the bed, vacant eyes wide open, gasping for breath. The ghastly image, seared into my mind's eye, was re-experienced every Sunday night for years to come, and turned bedtime into a losing battle against memory. Going to medical school was, among other motives, my counterphobic reaction to the terror of hospitals, sort of like becoming a professional cliff diver to get over a fear of heights. The thought of meeting Amanda tickled me in that sensitive spot for some reason. I became afraid again. But now, as I had done many times as a medical student, I beat down the fear and turned to the task in front of me. Right now it was time to introduce myself and attempt to interview Amanda Kay. I knocked and entered her room, accompanied by a nurse who had a tranquilizer medication at the ready. Several male staff members remained outside and watched us through the plexiglass. Amanda looked like she had been through hell. Seated on the bed and dressed in a hospital gown worked over with sweat, hair greasy and unkempt, she appeared simultaneously exhausted and wired. The room felt full of static electricity, an invisible energy ready to combust. To complete the strange scene, her arms shook with an uncontrollable coarse tremor. Whether caused by the medications she had received or her condition itself, the rhythmic flapping had a metronomic precision and closed the case that Amanda's brain wasn't in proper working order at all. "Good morning, Ms. Kay. I'm Dr. Mierlak. I'll be working with you here on the 5th floor. How are you feeling?" Amanda tried to cooperate, but her wheels were spinning too fast. With a breathless desperation, she launched into a series of pressured tangents, disconnected thoughts that conveyed great sadness, helplessness, and outrage. Her outward manner shifted uncannily from tears to threats, which induced a sense of vertigo in the room. It was like walking into the middle of an absurdist one-woman monologue that sped up by the minute. She was insistent the staff of the 4th floor had hurt her in the past. As Amanda accelerated, her anger started to feed upon itself. Ignition seemed imminent. I interrupted her. "Talking about this is very upsetting for you. Let us give you some medication to calm things down." Not missing a beat, the nurse stepped forward and offered the tranquilizer pill, which Amanda resolutely slapped out of her hand and across the room. What happened next I had never seen before. The staff stationed outside had witnessed Amanda's action and immediately entered the room. Amanda, superfueled by adrenaline and paranoia, saw her fears realized as the squadron of staff approached her and threw herself into their midst, flailing with an animal-like ferocity. The men physically subdued her and placed her face down on the bed. Out of nowhere, a hypodermic appeared. Amanda received her medication after all, injected deeply into the muscle of her buttocks as she clawed, spat, and howled at the injustice. It probably took 30 seconds in total. Rendered immobile as reaction to Amanda's loss of control and the staff's macabre choreography that sought to reinstate it, I quickly came out of my spell and remembered to breathe. No small feat, given that my heartbeat pounded against my eardrums. The staff assembled in the nurse's station after this event to have The Post, a review of the incident. Part quality control, part support group, the exercise occurred after every important incident on the unit. The staff knew I had never been through such a disturbing event. It was so early in the academic year. After a review of their actions, what went well, what didn't, whether it could have been avoided, they made sure to ask me how I was doing. That was kind, but I really wasn't sure at all how I was doing. Interns and residents received supervision on their casework from an assigned faculty member. These supervisory sessions were scheduled, like everything else, into the activities of the work week. This case was not suited to scheduled appointments, however. I sought out my supervisor for an impromptu talk, and we tried to make sense of what was going on and what had just happened. It was a highly speculative discussion. After that, I returned to my other patients on the unit, all of who seemed in excellent mental health by comparison, even Mr. Feldman. I did not see Amanda again that day. She was on autopilot with nursing. Just as well. I had stirred enough waters for one day. Amanda Kay's evening went poorly. She became agitated and threatening whenever staff entered her room with food or medication. Something went very wrong during the overnight, because when I came in the next morning, Amanda was in 4-point restraint. 4-point restraint is, just as it sounds, complete immobilization. The patient is placed on a bed or gurney on their back with arms at the sides. Padded leather straps are fastened to the bed frame, and then wrists and ankles are secured within the straps. It is impossible to get out of restraint by oneself, but one can struggle against them and work up a good sweat. Restraint is reserved for the most serious behavioral loss of control. It is an emergency procedure not initiated lightly. The patient has often committed a violent act against themselves or others on the unit and isn't de-escalating. They are not responding to redirection by staff or to medication, or they are not allowing medication to be administered. It's not a nuanced predicament. These patients are grossly out of control, and the intervention to restrain is designed to keep them and those around them safe from harm. There are strict protocols for these situations. For example, each restraint must be released every 15 minutes so that the limb can be flexed and its range of motion assessed. Most patients regain control of their behavior relatively quickly after being placed in restraint. The immobilization prevents further harm and safely buys time for medication to kick in and calm down. Amanda did not fall into this category. Despite 2 intramuscular injections of tranquilizer, she spent most of the night in a struggle against the restraints, as vile curses, spittle, and paranoid rants spewed unabated. The meds weren't touching her. Was Amanda some kind of elite neurochemical athlete? Then suddenly, like a fever breaks, she became calm. At the 11 a.m. limb range of motion assessment, she was cooperative. The nurses spoke with her and were reassured. They removed the restraints. Amanda took a shower and lunch was brought into her room. It seemed the crisis was settling down. I knocked at her door, entered, and attempted my second interview. Amanda was again seated on the bed in her hospital gown, half-eaten lunch nearby. The shower had made a big difference. Given the past 24 hours, she was eerily subdued. With an unexpectedly pleasant conversational style, we discussed her newfound control. I thought, okay, the meds have kicked in. We can work with this. Then she dropped the grenade. Where's my parnate? Of course, I remembered what happened at St. Vincent's 4 days earlier when Amanda asked them the same question. It would test my powers of persuasion, but ethically I had to tell her. What choice did I have? She seemed reasonable now, I told myself, and hopefully would understand why the medication had to be discontinued. I picked up the grenade and started to lay out the case. The parnate was fuel for the rage that led her back to the St. Vincent's ER and then to us, I explained. It had to be stopped to give her a chance to regain control. As I spoke, I saw Amanda's lucidity evaporate before my eyes. First the face, then the body stiffened and coiled.
Sample complete. Ready to continue?